Please let me know when we can start so that I'll be ready. Yeah. Can we start now? Yeah, please start. Yeah, welcome back to another interesting aspect of doc tutorials. So today I'll be discussing about the case that we have operated 2 weeks back in our hospital. So my name is Dr. Lakshmi Prasad and I happen to be a junior consultant in Kim Sunshine Hospital. So yeah, but just hold on for a second, just a minute. Welcome back. Welcome back to Doctor Tutorials. This is Dr. Lakshmi Prasad. So, in today's interesting case, I'll be discussing about a case that we have operated 2 weeks back in in our institute, Kim Sunshine Bone and Joint Institute. So, let me get into the details of it. So, it was a 29-year-old female who had complaints of pain in right knee from 4 months. No history of any trauma as of such, no history of fever, no history of weight loss and appetite. So, upon examination, what we found out was that there was mild erythema and swelling around the lateral aspect of the knee with mild local rise of the temperature. Uh, and upon palpation, what we found was that there was tenderness in the lateral aspect of right femur. And the range of motion, it was from 0 to 120 degrees, but the terminal part of the flexion was actually painful. So, and the distal neurovascular, we did see the distal neurovascular. What we found out was that ankle toe movements and both dorsalis pedis artery and posterior tibial artery were palpable. So what we did was that we were done with the examination part. Then we had a local lead. So in this picture, what you can see is that on the lateral aspect of the right knee, there is a mild swelling. If you compare it with the left side, and uh, you can also see a small scar here. So what does it signifies? I'll be discussing this part in the later aspect of the class. So coming on to the gait part, what we have seen, let me play the video once. This was her video. This was the gait. So if I had to describe this gait, then I would say that the patient had a bipedal unassisted gait with decreased stance phase on the right side and increased swing phase. That is suggestive that it is an antalgic gait. So this is how we need to, describe the gait whenever you are presenting it in your practical examinations. Moving on. Yeah, these are the X-rays that I got done. So this is a right knee AP and left knee AP projections, anteroposterior projections. It's a plain. So how do you describe this as well? So whenever you are given an X-ray in any of your examinations, what you need to say is that it's an right side. It's an anteroposterior projection. It's a digital radiograph of anteroposterior projections of both the knees, and this one, there's the lateral projection of right knee, which is showing an lytic lesion on the right condyle, right femur condyle. So in order to describe what is the lesion that is being there in that radiograph, all you need to say that yes, this is a anteroposterior projection, anteroposterior and lateral projection of right knee showing an expansile lytic lesion involving the epiphysiometaphyseal region. So this is how you need to describe your X-ray. So that can be seen evidently on the lateral projection as well. So the first thing that you need to think is whenever you get a 29-year-old female complains of pain in right knee from 4 months with difficulty in walking with a lytic lesion, so you should never come to a diagnosis straight away by looking at this. You should always try to say the differential. So what are the differentials that you need to think about whenever you get these type of things? So always try to say three differentials whenever you are giving your viva or yeah, viva examination or OSCE or whatever it may be. So always try to say three things. So one is giant cell tumor, one is aneurysmal bone cyst, and one is brown tumor or chondroblastoma, whichever you can say. So that is what I have been trying to say. But let me differentiate how these are different from giant cell tumor. If you see for aneurysmal bone cyst, yes, it is seen in less than 20 years of age, and because the lytic lesion was seen in the epiphysiometaphyseal region, aneurysmal bone cysts are usually seen in the metaphyseal region. And on MRI, what you get in these type of bone cysts is that you get a fluid-filled space, but that is not the case in case of giant cell tumor. Coming on to Brown's tumor, yes, Brown's tumor, also known as hyperparathyroidism. It is mainly because what are the differentiating features that differentiate brown tumor from a giant cell tumor is that it is multiple in number, and upon blood tests, what you say on blood investigations, what you see is that there is raised serum calcium, there is raised PTH, and there are multiple lesions. So that is what differentiates brown tumor from that of a giant cell tumor. Uh, coming on to aneurysmal bone cyst and the giant cell tumor, we have already discussed. Aneurysmal bone cyst more seen in metaphyseal region, whereas giant cell tumor is more seen in the epiphyseal region or epiphysiometaphyseal region. Giant cell tumor, even though it is a benign tumor, but it is notoriously known for its local recurrences. So even though it's a benign tumor, but it can have recurrences. So one has to be very careful about that. Coming on to the chondroblastoma, it is usually seen in 10 to 20 years of age. Even though the picture is similar, it is seen in the metaphyseal region. But the only thing what you see is that it is that the physis is still open in this chondroblastoma. So that's what differentiates it from a giant cell tumor as well. I hope you guys have understood how I'm trying to differentiate. So whenever you get a lytic expansile lytic lesion in the bone, in long bones, especially in the metaphyseal region, from second decade to fifth decade, most commonly think of giant cell tumor. Even though giant cell tumor can be also seen less than 20 years and also seen more than 50 years, but that should be our first diagnosis. Let us always go with the most common things rather than rare occurrences. So this is what the MRI film that was suggestive. As you can see in this is the one on the right side is an axial image showing a lytic lesion on the lateral condyle of the femur. The same in the sagittal sections. You can also see there is an hyperintense lesion suggesting that there is some effusion around it. And as you are going from medial to lateral, yes, you can see a lesion here that is occupying the whole of the lateral condyle of the femur. So this is another image of MRI which is showing the axial section. Axial section, you can see that there is a edema, there is an effusion in the knee joint with a lesion involving the lateral femoral condyle. The same has been evident in this. The same with this. And the same is shown in this sagittal image, which is occupying the whole of the lateral condyle of the femur. Yes, when you got when you see the MRI, it will suggest you that it's a well-defined lytic region with a narrow zone of transition. What is the zone of transition? The zone between the lesion and the normal bone is the zone of transition. So that is zone of transition. That is, it is always important that in any tumor case, you always try to mention about the zone of transition. Is it narrow? Is it big? Narrow zone of transitions are usually suggestive of benign tumors, whereas big or large zone of transition usually are suggestive of like metastatic or cancerous lesions. So that is what they have said. It's a well-defined lytic lesion with a narrow zone of transition showing hypointense signal and T1 and heterogeneous hyperintense signal and T2 with restricted diffusion. So X-rays and MRI are suggestive of giant cell tumor. So what will you do next? So once you are done, until and unless you are the treating surgeon, you never put anything on the patient. That is the best thing. So it has to be always referred to a orthopedic surgeon who does oncology cases, ortho-oncologist. So what is the thing that we do is that we need to confirm the diagnosis of giant cell tumor. So how do you confirm it? The confirmation is always by biopsy, and the biopsy should be also the least invasive biopsy that you need to do. So confirmation is always by biopsy. Yes, we got it done. We got it done in NIMS, and it was very much evident that it was a giant cell tumor. So this is how a giant cell tumor histopathological examination looks like. So basically, what do you see in a histopathological examination of a giant cell tumor? Yes, you have a spindle-shaped cells, mononuclear cells. So basically, a giant cell tumor has three types of cells. Uh, So the first type of cells is usually the interstitial fibroblasts. These are the spindle-shaped cells. These are actually responsible for the pinkish color which secrete the collagen. Then you have mononuclear giant cells that is very much evident here as you can see in this. Let me put it through a pointer. You guys will understand better, or highlighter will be a better option. So these are the spindle shaped cells that I'm trying to, okay, doesn't look good. So yeah, let me explain it with the marker only. Moving just a second, give me a minute. Yeah, this is the label, the laser marker. I this is getting lost in this. Let me put it in yellow, the laser marker as well. Yeah, no, I'm not getting it. Okay, leave it. Yeah, let's make it better. So, so whatever you see here, this is a it's a giant cell that is characteristics of a giant cell which has multiple nuclei and a single cytoplasm. Then you have spindle shaped cells, as you can see here, evident here. These are the interstitial cells that are actually responsible for the synthesis of collagen, or the collagen that is being laid down. And then you have type 2 the third type of cells are usually from the peripheral bloodstream, that are actually forerunners of the multinucleate giant cell. So what I'm trying to say is that they are they resemble a monocyte or a macrophage family, which undergo multiple multiplication and eventually forms the multinucleate gene cell. So this is how you need to identify a histopathological slide of a giant cell tumor. It has multinucleate giant cells. It has spindle-shaped cells which are rich of collagen. So that is how, this is the collagen part. This is the marker that the look at the mouse that I'm showing. So that has a lot of collagen that itself is showing. So this is how you need to identify. So any tumor, the identification is always by the biopsy, and the biopsy has to be done by the surgeon who is doing the final surgery as well. So that's what you need to keep it in mind. Moving on, let me come to the grading of it. Yes, there are two types of gradings in giant cell tumor. One is Campanacci grading, and one is the just a minute, and this is causing disturbance. Eraser. Oh, God. Sorry. Eraser part. Yeah. Yeah. Done. Yeah. So there are basically two gradings. One is Eniking grading and one is the Campanacci grading. So in Campanacci is usually used. Yeah, they ask you whenever you are in a Viva and you get a GCT, they ask the grading. So basically, both Enikings and Campanacci have three gradings. One is the grade one. It's a well circumscribed lesion with no aggressive features. What does the no aggressive features say? There is no periosteal reaction, no soft tissue involvement, and there is no cortical breach. Coming on to grade 2, yes, it is a well circumscribed lesion as well, but it doesn't have that rim around it. So basically, whenever you have a rim, that is grade 1. When there is no rim, then it is a grade 2. Then grade 3 itself is showing indistinct, ill-defined border with extensive cortical tissue destruction and soft tissue involvement. So coming on to the Anakin is also similar classification only. One is, benign, indolent or biologically static, that is stage 1, grade 1. Then progressive growth, but is limited by natural barriers, like cortex is a natural barrier. And the third one is locally aggressive with soft tissue involvement as well. So before I start into the treatment part, let us discuss some cardinal features of biopsy. I'll not go into details, but I'll just run through the slides in order for you to understand. Because the 12 rules of biopsy are the 12 cardinal rules of biopsy is an important long answer as well. So it's very important that you should see this, okay? The biopsy, as you told, as I always told, once you are done with your, radiological investigations, clinical investigations, then only you perform the biopsy. And biopsy should be never done before emerging. So that's the first cardinal rule of biopsy. It's a last investigation. And as I've already discussed, biopsy should be planned by the surgeon who is doing the definitive surgery as well. So one shouldn't do biopsy. No, like for example, this guy comes for a general orthopedician. He should not do the biopsy. It should be always done by the surgeon who will treat it. So it should be done by the ortho-oncologist because it helps in preventing wrong incision. It avoids contamination and also helps in limb salvage. Biopsy tract should be in the line of future surgical incision. So, what I'm trying to say is that this image, what you see here. So, this image is what is the scar of biopsy. So, whenever the ortho-oncologist does the surgery, it has to be in the longitudinal in the incision of the future surgery that is being done for the patient. So that's what you need to understand. So moving on. So what is that? Biopsy should be planned by the surgeon. That's we already discussed. Should be in the track with the future surgical incision. So when whatever the surgical incision should be in that line only the biopsy should be. So it should be later excised in toto that I'll be discussing in later. Transverse zigzag incisions are to be contraindicated. Avoid contamination of soft tissue plane. So it should go in a single plane. So no unnecessary dissection has to be done. No crossing of compartments has to be done. It has to be in a single compartment and no hematoma formation should be done because hematoma in return is associated with tumor spread. Because giant cell tumor is notoriously known for its, not notoriously, but in some cases, local recurrences can happen. So as a result of which, the hematoma has to be avoided. Use the least invasive possible. So basically in biopsies also we have core needle biopsy, incisional biopsy and excisional biopsy. So what we do in majority of the tumors, bone tumors is the core needle biopsy. Excisional biopsy is contraindicated in malignant tumors. It should be only done when there is superficial, small and benign lesions. Adequate tissue, at least 3 to 4 samples of the biopsy tissue has to be obtained, irrespective of what. And it should no, apart from histopathological examination, it should be always sent for culture sensitivity, immunohistochemistry, and molecular studies. Try to avoid crush or cautery damage whenever you try to get a biopsy. So if it is bleeding, one has to be very meticulous that it has to be adequate hemostasis has to be achieved in order to prevent hematoma. It prevents tumor cell spread. Biopsy tract must be removed in toto during the definitive surgery, as we have already discussed, because that tract might have that cancer, that tumor cells as well. So it has to be removed in toto. Drains should be avoided as much as possible, but if it is not, if it is a very extensive biopsy, then yes, we can put a drain. But in majority of the cases, try to avoid the drain as much as possible. Yes, the 11th cardinal rule is it has to be labeled properly. Correct site, name, age, sex of the patient, proper site of the patient. So it is very important that labeling has to be done properly. And the most important thing, Always relate it clinically and radiologically, because biopsy itself is never the diagnosis. So what is the what did we do in our case? What we have done extended curettage with a bone grafting with bone cement. So I'll go through the intraoperative pictures. The management. The management will change from stage to stage. In a majority of the cases, it is extended curettage with bone grafting. But in Campanacci grade 3, complete excision of the tumor is ideally advised. So, what is extended curettage? So, curettage is just removal of the scooping out all the tissue out. Extended curettage in a giant cell tumor is mainly divided into four types: mechanical, chemical, thermal, and cryo. So in mechanical, what we do is that we use a speed burr or a scoop. That is what we do in a mechanical curettage. That is, why do we do a mechanical curettage? Apart from removing the cancerous tissue, we have to remove a bit of normal tissue as well in order to prevent local recurrences. So that normal tissue that we will be removing is done by extended curettage. So it can be a combination of mechanical, chemical, uh, cryotherapy and thermal as well. So it should be always a combination. It should not be a single thing. So in mechanical, you have speed burr and a curette. In a chemical, you have phenol or hydrogen peroxide. Phenol tries to kill the cells by uh, protein coagulation, whereas hydrogen peroxide is cytotoxic. Then you have thermal. In thermal, you have polymethyl methacrylate, which mainly helps in extended curettage by thermal necrosis as it reaches up to 70 degrees of Celsius. Then you have cryotherapy. Cryotherapy, we may majorly use liquid nitrogen, but it is usually not used in a regular basis because of skin necrosis and the fracture risk after cryotherapy. So yeah, whenever what is sandwich therapy? So whenever there is, so I'll try to draw it in a draw it in a paper and show it to you. So whenever the tumor is involving the articular cartilage, bone graft, then we put gel foam, then you put the bone cement. Bones. So I'll try to show it. I don't know whether I'm visible or not. Let me see. Yeah. This is what I'm trying to explain, that whenever the tumor is in the lower aspect of the whenever the tumor is on the articular cartilage, what I'm trying to show is that the first layer what I've put is the bone graft. The second layer what I've put is the gel foam. And the third layer what I've put is the bone cement. So this is in this way the sandwich technique works. Let me share it back. Uh, just a minute. Yeah. Just, I'm still not able to share my screen. Just give me a couple of minutes. Yeah. So that is sandwich technique. So we put a level of bone graft. If it is if the giant cell tumor is involving the articular cartilage, In order to preserve it, we put a bone graft, then we put a gel foam, then we put a bone cement. So this is what I was trying to say. So that the incision that we have taken is along the line, longitudinal incision, which is involving the site of the biopsy. And the biopsy part is actually marked, you can very much see in this picture, and it is removed in toto. Then we entered it with bone, with speed burr. We tried to do, we have done the extended curettage part, as you can see, very much evident in this picture. Then we have put the phenol that is actually responsible for the chemical part of the extended curettage. Then after that, we put a bone cement. So this was the CM picture that we have got. So people might be asking, sir, why not put plate at this point of juncture? So there is something called Merrill's criteria. So whenever the tumor is involving 2/3 of the bone, at that point of time we put a plate. As it was less than 2/3, it was around 40% of the bone. So what we have done is that we have not augmented it with any plating. So this is the bone cement that we have put on that. And this is the post-operative X-ray. So the protocol is that we are not allowing her to bear weight for the next 3 months. ROM to be started after 3 weeks. Suture removal after 2 weeks. And after 3 months, once we get a repeat X-ray done, we'll make her walk. One more advantage of bone cement is that, as you can see in this picture, so there is a regular, definite distinction between the bone and the cement. But whenever there is a local recurrence, there will be some area of lysis here. So bone cement also helps us in knowing whether it has gone into recurrence or not. So that is the advantage of bone cement as well. Yes, the role of Denosumab. Is there any role of Denosumab? The answer is yes, definitely yes. It is a Rankel inhibitor. So what does it do is that denosumab goes and attaches on the Rankel ligand receptor activator nuclear kappa beta. That in turn prevents the activation of osteoclast, because denosumab is going and binding to Rankel ligand. So it helps in osteoprotect grid to form the further bone. Apart from denosumab also, we have zoledronic acid that has, in literature it was found that it is also useful in certain cases. So this completes today's uh, interesting case of chain cell tumor. Hope to meet you again in the next class with another interesting case. Thank you. Please go ahead. Yeah, in case of any doubts, you just let me know in the comment section. We'll try to clear out those things, and feel free to contact. Thank you.